Hemant Kumar, our president, Dr. Naveen Malhotra, Dr. Vishal Singla, all the GC members, and all of you from Rsacp, we welcome you to today's webinar. The theme being Airway, the clinical pearls from the experts. You've been hearing a lot about Airway in the last 2 years in various webinars. So today we chose some topics Dr. Rakesh Garg, who's a professor anesthesia at All India Institute of Medical Sciences, New Delhi. And he's a wonderful academician, clinician, and a great friend of mine. So the two of us will host this webinar. And we have 3 speakers today. And for the first speaker, I would invite our 2 chairpersons for this evening. I humbly invite Dr. Jyotsna Agarwal and Dr. Pratibha Pajia. Our wonderful chairpersons are both lovely ladies from the Hamdard College of Medical Sciences and Research, New Delhi. They're enthusiastic anesthetists who take keen interest in not only routine clinical activities, but a lot of academic and research work as well. Without wasting a lot of time, I would invite the chairpersons for today and hand over the first talk to them. Dr. Jyotsna and Dr. Pratibha, please. Thank you.
Thank you so much, ma'am.
Thank you so much, ma'am, for the welcome. And it is my absolute pleasure to be on this platform and to share it with Dr. Pratibha. So in the hospital and beyond hospital.
Same here.
Okay, so I'll just...
shall we start the first?
Dr. Apesh Patwa, he's General Secretary AIDAA, author AIDAA Consensus Guideline for Airway Management in OR during COVID-19 Pandemic 2019, co-author AIDAA Difficult Airway Guidelines 2016, winner ISA Academic Excellence Award 217, course director AIDAA Fellowship for Advanced and Difficult Airway Management, faculty in more than 150 state, regional, national, and international conferences, designed and developed Patwa Shah eye video laryngoscope, HUFLO oxygen HFNO device, awards 3 national and publications 12, book chapters 5. Dr. Apesh Patwa, it is our privilege and we invite you to start your talk. Welcome, sir.
It's really a pleasure to be here with all of you, and thank you, team Rsacp, for giving me an opportunity to speak on oxygenation effective tips. Why we need to discuss the tips on oxygenation? Let's have a video. This accident is happening. On another video, it's a model of Mercedes-Benz which prevents accident to happen by automatic activating the braking system once it senses the other vehicle in its vicinity. So it's provide more safety. So during oxygenation, if we are having a technique which prevents desaturation to happen, we are going to use this technique like this second car. So is this type of technique is available? Yes. Look at this case studies. It's 6 patients subjected for 10 minutes of apnea for a scan biopsy, and none of the patients developed desaturation. On another publications, it's a landmark publication of Dr. Anil Patel. 25 patients surgery were laryngopharyngeal surgery were performed with neuromuscular blockade without intubation, and none of the patients had desaturation less than 90 degrees, and duration of apnea was 5 to 65 minutes. How they did it? They did it with the high flow nasal oxygenation. And this is very interesting systematic review and meta-analysis of 2314 patient with number of RCTs. And the conclusion of this meta-analysis, high flow nasal oxygenation compared to conventional oxygenation reduces the risk of desaturations, increases the minimum oxygen saturation, and prolong the non-hypoxic apnea time. So, to understand the mechanism of high flow nasal oxygen, how they prolong the non-hypoxic apnea time, we need to understand the apneic oxygenation, and we need to understand SNAIF apnea window during induction. So SNAIF apnea window means it's a non-hypoxic apnea time, means it's an apnea time without any desaturation. To understand this, we need to understand the oxygen consumption that can be calculated by this Brody's formula. It's come to 3.5 to 5 ml per kg per minute. It's roughly for a 50 kg, it comes to 250 to 350 ml for a 50 kg. And FRC is our reserve amount of air which remains in the lung after normal expiration. And if you are inhaling air, the normal on an average reserve for an adult, Indian adult is 2.5 liter. And if you are inhaling air, the reserve contains 20% oxygen, means 500 ml of oxygen they contain among 2.5 liter of oxygen. So if we are subjected for a apnea on air, the non-hypoxic apnea time as consumptions of oxygen is 250 ml per minute is only lasts for 2 minutes. So we need to prolong this non-hypoxic apnea time. That can be done, one, by filling the reserve, by filling the oxygen into the FRC, or by increasing the volume of reserve, or by apneic oxygenation, or by HFNO and thrive. Let's discuss it one by one. So now, after optimal pre-oxygenation, suppose we are able to fill up whole of the FRC reserve, means now is having 2.5 liter of oxygen. Now this patient is subjected for apnea. The non-hypoxic apnea time metaphorically lasts for 2.5 liter divided by 250 ml comes to 10 minutes, but physiologically it lasts for 7 to 8 minutes. However, effectiveness of pre-oxygenation depend on how long you are pre-oxygenating, with what flow you are pre-oxygenating, and which circuit you are using. The literature describes the various methods of pre-oxygenation. The first method is 3 minutes tidal volume breathing, 4 vital capacity breath for 30 seconds, and 8 vital capacity breath for 60 seconds. Among these, 3 minutes tidal volume breathing and 8 vital capacity breath are more effective compared to 4 vital capacity breath. So in case of emergency, use 8 VC breath technique, and in case of plant surgery, use 3 minutes tidal volume breathing technique. And if you are monitoring end-tidal oxygen, and if it is more than 90% during pre-oxygenation, is suggestive of optimal pre-oxygenation. And when there is a leak in the mask during pre-oxygenation, you should have to prolong the pre-oxygenation time up to 5 minutes, which is as effective as 3 minutes tidal volume breathing with the optimal fitting mask. So simple cannula underneath the oxygen mask also improves the efficacy of pre-oxygenation. So what flow we should use? 5 liters, 10 liters, 15 liters. So suppose you are pre-oxygenated patient and patient is breathing deeply and his minute ventilation is 7 to 8 liters, and if you are supplying only 6 liters of flow, so you are not actually pre-oxygenating the patient with 100% oxygen. So minimal flow during the pre-oxygenation is 10 liters per minute. And if you are using open circuit, then 3 minutes pre-oxygenation time is enough. But if you are using closed circuit, then your pre-oxygenation time should be, after priming, it should be 3 minutes, or it should be 6 time constant plus 3 minutes. So this is very interesting graph. This axis showing the saturation, this axis is showing the apnea time, and this line is showing the 90% saturation line. So after optimal pre-oxygenation, if you look at the normal 70 kg patient, this desaturate to 90% at roughly 8 minutes. But children desaturate very fast at 4.5 minutes after optimal pre-oxygenation. And obese patient significantly is desaturate very fast at 2.5 minutes. Why it is so? Because in children and obese, there is less FRC, and in obese, with this FRC further reduces when you make the patient supine. And it, both of this group of patients, there are higher oxygen consumption, and that's the reason they desaturate very fast. So by pre-oxygenating a 20 to 25-degree head-up position, which significantly improves the FRC, and this is the reason it improves the non-hypoxic apnea time, and which ends up in higher oxygen tension in alveoli and oxygen. So all the patients under general anesthesia develop atelectasis. So this is interesting publication. What they did, they took a scan in awake state after induction, 5 minutes after induction, and 20 minutes after induction. Immediately after induction, all the patient develop density which persists throughout the surgery. And this represent atelectasis. And range of atelectasis development after pre-oxygen is from 4 to 21% of the oxygen, 21% of the lung volume. So what is the clinical significance? Suppose you have oxygenating a patient doing mass ventilation, and you are planning for intubation, you are not able to intubate, and then there is a sudden desaturation. So now you are reoxygenating. Now you are reoxygenating a patient after significantly less lung volume because of atelectasis. So further non-hypoxic apnea time is significantly less, and which is going to go less and less and less and less. So we need to prevent atelectasis formation, and that can be done by application of CPAP. So if you apply CPAP during pre-oxygenation up to 5 to 10 centimeter of HO CPAP, which decreases the sun fraction, increases the FRC, and in turn it increases the non-hypoxic apnea time by 20%. How to apply CPAP in a clinical practice? If your machine is having CPAP, just set the CPAP. If your machine is not having CPAP mode, then keep the apial valve closed at 10. Increase the flow, oxygen flow up to 50 liter, and optimal mass feeding will deliver 7 to 10 liter. Keep the apial valve closed at 10. Another way of pre-oxygenating a patient is through a CPAP and pressure support ventilator, non-invasive ventilations. So another way of improving or prolonging non-hypoxic apnea time is apneic oxygenation. It's just insufflation of oxygen through a nose. And this technique was first described in 1959 by Frumin in 8 patients. And all the patients were subjected for apnea after optimal pre-oxygenation and intubation, and he just insufflated the oxygen through the circuit. And the objectives were duration of apnea without desaturation, SO2, PaCO2, and PO2. And what he found? None of the patients developed desaturation. All the patients were having lowest reported saturation was 98, and non-hypoxic apnea time was ranging from 18 to 55 minutes. So he stated that under optimal condition, apneic oxygenation can indefinitely oxygenate a patient. So for another publication, here 9 brain-dead patients were subjected for apnea after intubation and pre-oxygenation for 10 minutes, and none of the patients become hypoxic. This is very interesting publication. Here, 5 female patients were subjected for apnea after optimal pre-oxygenation and intubation, and they have passed the 2.5 mm cannula in right and left focus and insufflated with the 500 and 700 of oxygen, and they have measured the PO2 at 5 minutes and 30 minutes. And results were quite astonishing. PO2 was 299 average in all the patients at end of 30 minutes. So whether you believe or not, apneic oxygenation maintains the oxygenation and prolongs the non-hypoxic apnea time. How apneic oxygenation work? As we discussed, we require optimal pre-oxygenation. Suppose this is alveoli fully filled with the 100% oxygen. And this is underlying vessel. So there is a partial pressure gradient between alveoli to blood for the oxygen, which causes passive diffusion of oxygen molecule from alveoli to blood, which create a negative subatmospheric pressure into the alveoli. And 250 ml of oxygen going to be consumed from the blood vessel. And because of this subatmospheric pressure into the alveoli, which draws the gas from the pharynx and from the upper airway that is insufflated with the high flow oxygenation. And as 250 ml of oxygen is going to consume, and alveoli is again filled with the oxygen because of passive drawing of the gases because of negative pressure. Again, there is a partial pressure gradient. Again, there is a diffusion of oxygen from the alveoli to blood vessels. This cycle goes on and on. That's called apneic oxygenation. So whatever the technique, whatever the publication we discuss, all the publication, the study were done with the intubated condition. Is it possible to apply this apneic oxygenation technique during induction? Yes. Without intubation during induction? Yes. That's called no DSAT, nasal oxygen during effort securing a term, and term is given by Dr. R. Levitan. A nasal cannula which is set at 15 liters per minute is an effective way of providing apneic oxygenation. What are the requirement of, or what are the prerequisite of apneic oxygenation for its effectiveness? There should be optimal pre-oxygenation. Means alveoli should be filled with the 100%. All FRC should be filled with the 100% oxygen. Always use nasal passage, because once you are insufflating oxygen through the nasal passage, is going to underneath the through the nose to underneath the tongue to the pharyngeal area, and which can able to generate 2 to 3 centimeter of H2O CPAP. There should be patent airway. There should not be any collapse of airway. So if required, give jaw thrust and keep high flow 15 liters per minute. So be tension free. Now you are having a technique which increases the non-hypoxic apnea time during induction. The limitation of this apneic oxygenation is the accumulation of CO2. The first minute of apnea leads to 8 to 16 of Hg accumulation of CO2, and every minute of apnea there will be increase of PCO2 at the rate of 3 ml of Hg per minute. Another limitation is a high dry and cold gas leads to hypothermia, mucosal epithelial ulcerations, CO2 accumulations, and if it has been given in awake state, it's not many times it's not tolerated by awake patient. So another way to improve oxygenation is high flow nasal oxygen to devices. So these devices are having capability of delivering 70 liter heated humidified gas. So in this article, what we discussed at first for a laryngopharyngeal surgery, and when high flow oxygen is delivered in a paralyzed patient, is called transnasal humidified rapid insufflation ventilatory exchange. And what they did in this during these publications, a 25 patient for laryngopharyngeal surgery, they are able to maintain the saturation with high flow nasal oxygenation without intubation with neuromuscular blockade. And when you are using the high flow nasal oxygen in a spontaneously breathing patient, this publication labeled this as a strive high, a spontaneous respiration using intravenous anesthesia and high flow nasal oxygen, and they were able to maintain the airway patency and oxygenation even in patient with subglottic stenosis. How it works? So high flow oxygen delivered up to 70 liters per minute oxygen, provide high FiO2, it's humidified gas, it can generate the CPAP, and it can wash out the dead space and provides the ventilated CO2 exchange. How it works? What's the mechanism? What are the potential mechanisms? It decreases the work of breathing when applied to the spontaneously breathing patient by reducing the energy requirement of gas conditioning. It, because of high flow, reduces the upper airway resistance. It decreases the work of breathing. And humidified warm gas decreases the viscosity of secretions and increases the mucociliary clearance and increases the comfort. Because of it's possible to deliver 70 liters per minute, it's easy to match the peak insulated flow rate of the patient. So there will be less air entrainment and dilution of oxygen. And that's the reason it's possible to provide even 100% of oxygen. When you are delivering the high flow through the nasal cannula, which is going underneath the tongue, which can generate 3 to 7 centimeter of Rsacp in the upper airway as well as in lower airway with the closed mouth, and it maintains the airway integrity because of CPAP. And because of high flow, it leads to distress, pharyngeal distress washout, and it augments the CO2 elimination. Look at this. This is showing the washout at 15 liter, 30 liter, and 55. There's significantly higher washout at 55 liter per minute, and which is more higher at 70 liter per minute. So by flushing the dish space, it augments the CO2 washout. So if you look at the usability, it's like a mobile application. You can use it, high flow nasal oxygen, you can use it for pre-oxygenation. You can use it for apneic oxygen in upper airway surgery, tracheal surgery. You can use it after post-activation to maintain airway integrity and improve the oxygenation. It can be used with the sedation for an endoscopy, for CT scan procedure, for physiological difficult airway. Even in high-risk patient, if you're conducting regional anesthesia in obese patient with sedations and at that to improve oxygenation and maintain patency, airway patency, you can use high flow nasal oxygenation. It can be used in difficult airway management. So it's having potential higher advantage of using high flow nasal oxygenation in OR. However, there are a number of limitations, but because of lack of time, I'm not going to discuss that limitation. So now you are aware of what is optimal oxygenation. You are aware of what is high flow nasal oxygenation and what is thrive, which prolongs the non-hypoxic apnea time to a significant level. So apply this technique clinically to improve your patient safety. Thank you.
Was a very well covered topic, sir. You really gave a lot of details about pre-oxygenation, apneic oxygenation, and HFNO. Very, very informative.
Thank you, sir, for such an informative and crisp talk on this very important, it's a basic skill, I think, which every PGs must be practicing day in and day out. So it's very important for them to know the basic, the basic physiology and the physics behind each step. I think you have explained very well. Are there any questions in the chat box? Sir, I just wanted to know that the basic principle of this pre-oxygenation or apneic oxygenation is the patent airway. We should have patent airway. Yeah. So is there any technique or the modification of something which can help in those patients where obstruction is in the patients with the obstructed airway, upper airways obstruction is there?
Yeah. See, when there is obstructed airway, so it's not possible for the alveoli with the negative pressure to draw the gases from the pharynx. So there has to be patent airway. So there are a number of modifications we can do. You can give a jaw thrust. That is one of the options. Second option, you can pass the nasopharyngeal airway and oxygenate through the nasopharyngeal airway with the 15 liter of flow. So what you can do, you can pass the nasopharyngeal airway and connect the endothecal tube connector at the proximal part of the nasal airway and connect the nasal airway with the circuit and insufflate the oxygen 15 liter per minute. So that will maintain the patency even during the sedation and even during the pre-oxygenation and even during the after giving the relaxation. And another, there are few studies coming out with the nasal airway pre-oxygenation as well as ventilation through the nasopharyngeal airway. You don't need to handle the mask. You can directly ventilate the patient through a circuit to the nasopharyngeal airway. Yes. An important thing, as BMI is increasing, if patient is more if patient is more obese, so ventilation efficiency improves with higher BMI patient because there is a narrow pharynx and nasal airway appropriately fit with the narrow pharynx. So the theory and hypothesis is changing your 180 degree now.
Okay. Thank you, sir. Sir, there is few this literature saying about buccal oxygenation. How does it help? I mean, oxygenating this tube they just fixed near to the buccal cavity. So how does it go? It's not going to the pharynx. So how does it help?
See, important thing. See, buccal oxygenation is keeping a small sort of a cannula and fix it with the at the lip and is going near the buccal area. Oxygen is insufficienting at the buccal area. But important thing, whatever the technique you use, there has to be patency for apneic oxygenation or pre-oxygenation. That is very important. So you should be sure of maintaining airway integrity, whatever the way you oxygenate the patient.
Okay, sure. Sir, do you have any experience that as this apneic oxygen increases the apnea time, so in a healthy patient where pre-oxygenation is by default one of the steps of apneic oxygenation where we increase the apnea time, and moreover we are practicing apneic oxygenation as well with the help of nasopharyngeal or oropharyngeal cannula, not with Thrive. So where is the risk of accumulation of CO2? So is there any scenario or you have any experience with where there is an acute increase in CO2 and though the patient is maintaining the saturation?
So that is the possibility. So if you are continuing with the application, you are able to maintain the oxygenation, but at the same time CO2 is going to rise with the apneic oxygenation compared to HFNO. With HFNO,
yeah, of course,
there will be compared to HFNO, that is important. So and it's not possible to measure the EtCO2 when you are providing the apneic oxygenation. That is, so you need to limit the apneic oxygenation at certain period of time. That is important thing. Either 15 and 20 minutes. And usually as a mathematical calculations, every minute of apnea, there will be a rise of PCO2, TMM of Ig.
Okay.
So accordingly, you can calculate and limit the apneic oxygenation.
Yes. So there is one
and important thing. See, hypoxia kills, hypercarbia not.
Yes, right.
This is very important thing. So if you are in if you are doing a rescue with the apneic oxygenation, you are not able to do. You can accept the hypercarbia, and once you are able to rescue the patient, once you are able to intubate the patient, then adjust the ventilating setting in such a way you can easily wash out the CO2.
Yes, very well. There's a buffer system for CO2, definitely not for the oxygen. Yeah, there's one question in chat box, sir. Any concern of oxygen toxicity during this oxygenation with high flow and 100% oxygen during airway management?
Yeah, sir, important. There is a lot of misconcept about the oxygen toxicity. What you mean by oxygen toxicity? So actually, oxygen toxicity, usually high flow oxygen or as FiO2 increases, there are higher chances of atelectasis. That causes compromised gaseous exchange. So we need to improve the gaseous exchange even if we are delivering high FiO2. So that can be easily done if you pre-oxygenate the patient with CPAP. So keep the alveoli open, and there is that concept that's come in 2017. That's called open lung concept. So start with CPAP, continue with the CPAP, and extubate the patient over the CPAP, and continue even the post-op with the CPAP. That's called open lung strategy. Means you are not allowing any of the alveoli to collapse throughout the procedure of anesthesia, from pre-oxygenation to extubation.
So yeah, here I just want to stress upon this thing that most of the time we were talking pre-oxygenation in terms of during induction, but it is equally important, I think, during extubation as well.
Yes.
We usually never focus on pre-oxygenation during extubation. Yeah, so there's one more question. do we need to practice this pre-oxygenation irrespective of difficult airway? I think there's one question there.
Yeah. See, if not contraindicated, always use CPAP in all the patient during pre-oxygenation.
So they are asking, do we pre-oxygenate all the patients irrespective of whether they have difficult airway or not? Do we need to pre-oxygenate in all situations?
Yes.
Books
As far as
yes.
yes.
As per literature, yeah, for PGs, they should.
As per guideline, yes.
They should.
There are few literature, I don't want to talk in present. See, with FiO2, there are high FiO2, there are high chances of atelectasis. That is apart. And few literature are suggesting to use pre-oxygen with the 80% FiO2. But as per the guideline, as per the protocol, and for PGs, pre-oxygenate with the 100% oxygen, with CPAP, with head-up position, if not contraindicated.
Yeah.
And also, Apesh, what I would like to add is that with 80%, with the presence of nitrous oxide, and if your FiO2 is not one, that is, if you're not pre-oxygen with 100% oxygen, your apneic oxygen will also not
going to work.
So to work apneic oxygen effectively, you need to have 100% oxygen.
100% oxygen.
Yes. Okay, so is there any okay, I can ask one more question, I hope, Dr. Rakesh. Sir, your experience of HFNO or Thrive in pediatric age group?
Yeah, see, my main practice is in the adult age group. I have not used HFNO much in the pediatric one, but as far as flow is concerned, it's a pediatric age group. A lot of people are using in the ICU, but as far in perioperative period, it's 1 liter per kg. That's the approximate flow you should use during the pediatric age group.
Dr. Pratibha, it's been a very nice session, but we need to move on.
Yeah, thank you so much, sir.
Thank you.
Being such pioneers here, you have a lot more questions to ask them. Thank you so much, ma'am. Thank you so much, sir.
Thank you so much, Dr. Apesh. It's a very wonderful.
Thank you so much. Let's move to the next very interesting session. Thank you, Dr. Jyotsna Agarwal and Dr. Pratibha Paneja, and thank you, Dr. Rakhi, for taking it forward. So let's move to another very interesting session, and it is coming directly from the horse's mouth. I mean, directly from the experts who has done. I know them personally, and they have done wonderfully. They have in-depth knowledge of what exactly video laryngoscopes looks like from inside and outside. And I think he's the most apt person to speak on this interesting topic, yet clinically very important. And the topic that he chose to speak and share with us is video laryngoscope tips and tricks for the success. So, and we have equally able chairperson who are airway enthusiast, Dr. Amit Kohli, Associate Professor from Maulana Azad Medical College. He is well known for conducting various advanced airway workshops throughout India. He is quite popular in conducting quality workshops. He has many publications. He is also the governing council member of ISA Delhi, and he has received numerous awards at national and international platform. Welcome, Dr. Kohli. I also welcome Dr. Samiksha Khanduja. She is also associate professor at himself. She has numerous publications in national and international journals, and she is course director for various structured programs. She is also conducting very well appreciated CMEs in Delhi. Those were very popular, very well conducted. Welcome, Dr. Samiksha. Over to you.
Thank you, sir. Should I introduce sir?
Yes, please. Yes, please.
Okay. So the speaker for today for this, the patent topic of video laryngoscopy and its tips is Dr. Amit Shah. He's the director and consultant anesthesiologist in WINS. And of course, his areas of interest are advanced and difficult airway management, advanced neuro and laparoscopic anesthesia. He is the inventor of the very innovative Patvasha video laryngoscope, and HU Flow O2 high flow nasal oxygen devices. He is the treasurer of All India Difficult Airway Association, and he received an Academic Excellence Award, the Bhopal Award for Academic Excellence in 2017. And he is known for a significant contribution to the Anesthesia Society, and he got the ISA Presidential Appreciation Award twice. He is also the co-author of Airway Management Guidelines in COVID-19 in 2019. He's got numerous publications, and he's the organizing chairman of National Airway Conference, NAC 2016. It's a pleasure to hear from the man himself. Sir, please.
Good evening, dear friends and colleagues. At the outset, I would like to thank Dr. Indrani Madam, Dr. Vishal Singla, Dr. Rakesh Garg, and Dr. Rakhi Goel for inviting me to this Rsacp Academic Webinar Series 2022. And also, I like to express my gratitude towards my chairpersons. I'll be speaking about video laryngoscopy tips and tricks for the success. At the outset, I must disclose that we have developed a video laryngoscope device, but the views expressed here are our personal experience, belief, and evidences, and are not to compare device with our device. This is our laryngoscopy goal, to visualize larynx adequately so that you can pass the tube. Sniffing position is routinely recommended to achieve this view, but how sniffing position achieve this is not very clear. And to propose it, there are various theories proposed. One of the most important theory which we have been following so far is a alignment of 3 axes. But Adnet contested this theory and said that actually axes are not aligning, but still sniffing position improves our vision. And so other theories were proposed. One of important is 2-curve theory. And why we are discussing that is, it is important to understand video laryngoscopy through this 2-curve theory. There are 2 curves: primary curve, oropharyngeal laryngeal curve, and second is pharyngeal laryngeotracheal curve. And the meeting point of these 2 curves is in front of a glottic opening. Now, in the sniffing position, both curves are obtunded, and then with the force of laryngoscopy, you take tongue away and achieve the direct line of sight. But whatever theory you use or whatever force you use, we still end up in such a view. But we don't fail from, even after getting such a view, because of use of multiple attempts, bougies, manipulation, and so on. Is it acceptable? No, it is not acceptable. It is considered near miss if you intubate in spite of difficulty, because you may fail next time. So how can you avoid this? Now, if you look at this, the position routinely, if you are able to give position, will obtend both the curve, but what you need extra is the force to take tongue away or the compressed tongue. If that is not possible, then many times you will face the difficulty. So how can you avoid that? If you can go beyond curvature of tongue instead of looking from outside, then it becomes very easy. You look inside, you go beyond curvature of tongue, look towards secondary curve. So you don't need any force. You don't need to align axis. Proper position may not be mandatory, and you get a large field of view. The device looks around corner of tongue is called indirect laryngoscope, and if you use video laryngoscope camera, it is called video laryngoscope. So the term video laryngoscope device is the device in which video camera is used in place of line of sight visualization to accomplish endotracheal intubation. Video laryngoscope not only improves laryngeal view but also foster a teamwork. Now here all your assistant and everyone of the team knows what is happening inside. They can also visualize what you are visualizing, and that helps us in various ways. They are called non-technical benefit. It becomes from one laryngoscopist procedure to a procedure performed by a team. It can optimize intubation attempts by, assistant can give optimum external laryngeal pressure, or also prevent errors like esophageal intubation, as many people are trying to see and can guide that it is probably going into esophagus. It is also possible to record this for the teaching purpose as well as the legal documentation. Now, when we were using direct laryngoscopy, our options were few, but with the video laryngoscope now we know that there are many different type of a video laryngoscope. and we really need to understand them, differentiate them, classify them to optimize intubation attempt. So we'll try to learn that in this particular lecture. So what basically you need to understand different types of video laryngoscope is their blade part, which goes inside the oral cavity. Each device or blade has a different angle and shape, and we can broadly classify them into three types of device. One which was first to develop was glide scope, which is hyper angulated blade, so the tip almost points towards vallecula. That is hyperangulated device. It is actually almost 30 to 40 degree up from the baseline. Next to develop was a channeled video laryngoscope to accommodate the endotracheal tube into channel so that you can make the intubation procedure easy. To incorporate channel and channel aided intubation, the curve is slightly flattened, so it is slightly less curved but still anatomically shaped. It is still anatomically curved but less angulated compared to hyperangulated device. And then of course, the camera can be incorporated in Macintosh type of a shape, Macintosh shaped blade. So on this basis, video laryngoscope can be classified in anatomically curved and non-anatomically curved. Non-anatomically curved can be further identified as angulated channel video laryngoscope or hyperangulated non-channel video laryngoscope. And non-anatomically curved is Macintosh shaped device. To understand it further, you should know angle of blade, which you have already understood. Also, it helps us in understanding the direction of camera or angle of vision, and also what is field of vision. So again, angle of blade we have already seen: hyperangulated, angulated, anatomically shaped, channeled, and Macintosh type of a device. Also, if you carefully observe, the camera in anatomically shaped angulated device, which has a channel for a video tube passage, actually is less angulated and the camera looks straight towards laryngeal opening. Well, in case of hyperangulated blade, the camera is slightly nearer and it is actually looking up towards larynx. Well, in case of Macintosh, it is actually looking straight, but our direction of video laryngoscope blade is downward, so it is downward. Also important is field of vision, how much area is visualized. If you can visualize entire hypopharynx and larynx both, or you can visualize only larynx. That is important for maneuvering of the endotracheal tube. Here, if you look at in this first video, you can carefully see that there is hypopharynx and other area is seen and tube passage. And if it goes somewhere else, you can easily identify. Well, in case of this, the laryngeal view is good, but it is too close and you don't see the endotracheal tube if it goes sideways. So it becomes difficult if field of view is smaller. The important issues of video laryngoscopy when you compare with direct laryngoscopy, you already seen there are different type of device. Second is hand-eye coordination. That means you are looking somewhere and intubate somewhere that we were not doing earlier. So you need to have to learn that, and there is a learning curve for that. And also there is a difficulty in advancement of endotracheal tube. It is more common with the anatomically shaped device, which is angulated channel or hyperangulated device. Most of the time it is identified it is due to lack of knowledge and inexperience. You must know that there is a learning curve with video laryngoscope, and once you overcome that, then your chances of intubating with the video laryngoscope improve drastically. So first we'll understand how to intubate with a hyperangulated non-channel type of a video laryngoscope device. As we already seen, the camera looks up towards larynx. It is hyperangulated, pointing almost towards vallecula. So routinely epiglottis will not block your view and your requirement of force is minimum. So view is optimum without undue force in hyperangulated non-channel type of a video laryngoscope device. But many times it has been seen that when you get optimal view, sometimes we are too close to the glottis, and then if you're too close to glottis, your view is optimum, but your endotracheal tube may not reach there. So you need to it improves your success rate if you have sometimes suboptimal view. You withdraw blade to achieve a partial view like grade 2A view, and then your intubation success improves. Also, what you can do is to divide this screen into 3x3 grid, and if your laryngeal opening is in the middle window, then your intubation success is higher. When you pass endotracheal tube with the hyperangulated device, it actually passes through two curves of upper airway. First, it goes anteriorly to meet at the glottic inlet because it is hyperangulated blade, anatomically shaped, and then it goes downward. So this requires a special shape because our routine PVC shaped is not PVC endotracheal tube is not shaped like that. So you need to use a steelet to change the shape so that it becomes hyperangulated and it goes towards the laryngeal opening as per the shape of your blade device. All devices are all devices are routinely supplied with their dedicated steelet. But if you don't have one, you can use your conventional steelet to make it shaped according to your angle of your or the shape of your blade, and then you can use it with that particular video laryngoscope device. Once you have reached larynx, if you advance it further because of hyperangulated shape, it will go and hit the anterior tracheal wall, can cause impingement as well as trauma to the tracheal wall. Actually, you need to go down from the laryngeal opening into the trachea. So what you need to do is to first what you can do is hold or withdraw the steelet at larynx and then advance only endotracheal tube. That is very, very important. Carefully observe here my movement when I am introducing endotracheal tube. This is a CMAC D blade, a wonderful view. I am introducing endotracheal tube which is curved according to the shape of the blade. I am introducing into the oral cavity. Once it reaches larynx, observe my tube movement. I am only advancing endotracheal tube with one hand while my index finger is actually holding the steelet. Either you can do it on your own or you can ask your assistant to hold the steelet and advance only endotracheal tube. Or you may withdraw a steelet slide and then advance only endotracheal tube. The other things which you can do is to use technique called reverse loading of tracheal tube. Or you can do anti-clockwise rotation as you are actually advancing the tube. Or you can also use a smaller size endotracheal tube or a flexible endotracheal tube or a tube which has a soft inward folding tip like Parker flexi tip or intubating LMA endotracheal tube. So how to do counterclockwise rotation? If you carefully observe here, as I am advancing the tube, I am rotating the tube so that it moves downwards. So this is counterclockwise rotation while you are advancing the tube. Or when you load endotracheal tube over a steelet conventionally, the bevel faces the left. If you rotate that tube on the steelet so that the bevel faces on the right side instead of left side, that is called reverse loading. And then when you advance the endotracheal tube, it will take its natural shape and go down instead of going up towards the tracheal opening. This is called the reverse loading of endotracheal tube. A sniffing position is counterproductive with the hyperangulated device, and neutral or ramp position is better compared to the sniffing position. So essentially anatomically shaped hyperangulated non-channel blade looks up towards larynx. You don't require to give much of the force, but sometimes suboptimal view may help you to improve your intubation success. You need specially shaped steelet to reach the larynx. When you advance it further, you are likely to hit anterior tracheal wall, so you need to hold the steelet or withdraw, or you may use flexible endotracheal tube, or you may use techniques like reverse loading, and sniffing can be counterproductive. Channeled video laryngoscopes blade are anatomically shaped, less angulated compared to hyperangulated device. They look straight towards larynx, so epiglottis may block your view, and what you need to do is to apply some force to achieve optimum view. In fact, many times beginners are or incorrectly trained personnel tend to insert this blade too deep, which prevents optimal device positioning and making intubation almost difficult or impossible. So you should not go too much in. You may need to withdraw it, and again suboptimal view may help you. Because there is a dedicated slot for the tube passage, tube delivery towards larynx is and into trachea do not require any further instrumentation. But because dedicated slot for the tube passage, tube track and view axis are connected, it goes only in one direction. And if your larynx is not in that same direction, you need to alter the direction of endotracheal tube passage. And to do that, either you can use maneuvering of a device or maneuvering of the endotracheal tube. So first and foremost, if you look at carefully as tube comes out from the slot of channel slot, it goes down and then natural shape of PVC tube takes it up towards larynx. So if you are too close to the glottis, then you are likely to have difficulty in your tube will go towards interarytenoid membrane. You need to do two things: slight withdrawal and lifting up force of a channel video laryngoscope device helps you to improve your intubation success. Also, side-to-side movement help you to align your endotracheal tube trajectory towards laryngeal opening. Also, what you can additionally do is to use the tube rotation as you are advancing. If you rotate it in either direction, it will go into a different direction. Suppose if you rotate it counterclockwise, the tube will go towards left side. Right epiglottic fold impingement is very common, and to avoid that, you can do counterclockwise rotation of endotracheal tube in the channel. And when you do that, it will go towards left, towards glottic opening, and then you can straighten it. So all in all, you don't need to go too close. Lift up, slight withdrawal or side-to-side movement of video laryngoscope helps, or you can rotate endotracheal tube while you are advancing in the channel. If you compare this anatomically shaped hyperangulated and a channel device, both devices introduced from the center of mouth, new users find it difficult to insert. Sniffing may lead to difficulty in intubation. Hyperangulated device gives you better visualization without undue force, while in case of anatomically shaped device, epiglottis will may come in your view and you require some lifting force. Hyperangulated device requires stellate, and because of stellate and some more movements, it is taking slightly longer time to intubate. While in case of video laryngoscope, channeled video laryngoscope, you don't need stellate, but you need to maneuver video laryngoscope device or endotracheal tube, and intubation times are comparable to direct laryngoscopy. There are risk of pharyngeal injury, especially with hyperangulated non-channel type of video laryngoscope device, because there is a creation of blind spot. When you introduce endotracheal tube beyond curvature of tongue, till it reaches in your view, there is an area which is not visualized, which is a blind spot and can cause pharyngeal injury. So whenever you introduce endotracheal tube, actually you have to look inside the oral cavity and try to avoid injury as far as possible. Macintosh type of non-channel blade, there are various types of device available in the market. In this case, since the procedure, pressure and displacement are almost similar to the conventional, you may or may not require stellate. It can be introduced from either angle of mouth or from the center of mouth and may require to displace tongue laterally. So it is very good for the teaching where the student is doing direct video using Macintosh type of a video laryngoscope to do direct laryngoscopy, and while teacher is observing from outside what is happening inside. But its role in difficult airway or a rescue airway has been questioned. As already described, it can be introduced from center of cavity or from the angle of mouth. You can directly visualize inside or you can view it on the screen. You may or may not use stellate, as I am here intubating without use of stellate. There are various types of device which are available in the market which are similar to the Macintosh type of a blades. And what I have found and also described in literature, that routinely bougie is actually of no use, especially in anatomically shaped device, because bougie cannot maintain its shape. So it is not useful in those devices, but it can be used in Macintosh type of a device if you face difficulty of passing the endotracheal tube. But again, it requires experience. After certain experience, probably you can use bougie also. especially with Macintosh type of device. It is not useful with the angulated, anatomically shaped devices. So golden rules for the successful video laryngoscope: you should check the device battery, charging, and anti-fogging functions. Apart from, when while you are using direct laryngoscopy, you just need to check whether light is working or not. Angulated and or a channel blade video laryngoscopes are these devices are introduced from center of oral cavity. Sniffing position may not be mandatory. Sometimes it is counterproductive. Always look inside oral cavity whenever you are introducing either device or endotracheal tube to avoid pharyngeal injury. Experience with standard Macintosh does not mean that you will have equal skill with video laryngoscope. Experience with one type of video laryngoscope does not equate to the skill with all video laryngoscopes. Again, a good view of video laryngoscopy view does not mean that you will have equal intubation success. Buji may not be a solution, especially in angulated or anatomically shaped device. And video laryngoscope must be chosen according to the indications. They can be broadly divided into 3 situations. One is routine use, where Macintosh type of device is more helpful. But we have also seen that channel video laryngoscope devices takes your equal time for the intubation, and with some experience you can use it. But if you are in a rescue or anticipated difficult airway, then it is always desirable to use hyperangulated blade or a anatomically shaped channeled video laryngoscope. But if there is a blood in the airway, I think only Macintosh type of device can be used, because it will, if you are not able to see it on the screen, you can directly see inside. Thank you very much for your patient hearing. Good evening, dear friends and
Thank you so much, sir. And actually, I think all of us, when we were in a stage of beginning to learn this video laryngoscopy, we were going through this laryngoscopic paradox, seeing the view, but not able to pass in the tube. So that was always, so these tips are really going to help us a lot. So I just wanted to know, what is its rationale in awake intubation if you compare it with the gold standard and all?
Yeah, like there are certain situations where fiber optic is only options, like if you don't have mouth opening. But if you have mouth opening, what we have found that it is equally effective. You can very easily use it with minimum of anesthesia, and the success rate, if mouth opening is adequate, are almost same as fiber optic intubation. And here you can see the passage of endotracheal tube going inside the larynx. While in case of a fiber optic intubation, your intubation is actually blind. You go inside trachea, but when you are sliding the tube passage into larynx is actually blind. So it is very good, very effective. If you are comfortable with a video laryngoscopy, then you should use video if mouth opening is of course available. If mouth opening is not there, then you have of course difficulty and you have to use fiber optic only. But we have seen many cases where we have used awake video laryngoscopy effectively.
Can I add something, Dr. Rakesh or Amit?
Yes, please.
Yeah, please.
Yeah. See, important thing, which type of device or video laryngoscope we are going to use for awake. That is very important. If you specifically, when patient mouth opening is narrow, but not completely closed. So in such case, you should use the video laryngoscope depending on the anterior posterior depth of the blade. If you take the King Vision, is 13 mm depth anterior posterior. So in such case, you can use 13 mm. Another important thing, Macintosh type of video laryngoscope usually should not be used for narrow mouth opening for awake tracheal intubation. You are not able to get the view.
In fact, what I feel is that
Macintosh type of video laryngoscope,
it should not be used at all, because it is not anatomically shaped, and pressure required is actually high, which is difficult in unanesthetized patient. So anatomically shaped blade like a channel hyperangulated device or a channel angulated anatomically shaped device should be used. And I think we should try to avoid Macintosh as far as possible for
So that's a very important message. So when you are selecting a patient for a awake video laryngoscopic intubation, so then you should select the device as per the anatomically curved blade.
Certainly, I totally agree with that. To the esteemed people, I really want to add on that we have been doing since last 3 years, 3 consecutive theses on awake video laryngoscopy guided intubations at Maulana Azad Medical College, New Delhi, my own postgraduates, right? That is there. So as far as the difficult airway is concerned, Dr. Patwa and has very, very rightly said that anatomy is very important. And another important thing is the device which you are very familiar with in usage. Don't use in a difficult scenario a device which you were not very comfortable initially and you haven't used it in an elective scenario. That is one important thing. And as far as if the airway mouth opening is not limited, even the Macintosh variants can be used if the preparation of the patient is good. Awake video laryngoscopy, the preparation of the airway matters a lot. And along with using of sedatives like dexmedetomidine, which we are using very, very commonly during the awake video laryngoscopy, it increases the success rate of awake video laryngoscopy to a great extent.
Okay, sir, just one last thing. We've seen so many video laryngoscopes all having different indications, you know, some particularly for difficult airways, some showing more benefit in a normal airway. So if given to choose one, which one to buy, say King Vision or Rsacp D-Blade, which one should we go for? I mean, considering everything that we've got a learner's curve and postgraduates will be learning also and all. We can just buy one. So
if you have experience of using video laryngoscopy, right, then I think D-Blade is must, because in the situations of difficulty, I think that is a first preference. Okay. Between King Vision and Rsacp D-Blade, there is little more, in the sense it depends upon your experience and your personal choice. But between Macintosh blade and D-Blade, if I have to choose only one blade, and if I am experienced, then I'll go for a hyperangulated device. But if I am in a setting of a medical teaching institute, where if I'm going to use it regularly for my normal patients, then I should have both Macintosh as well as D-Blade. But if I have to choose only one, you know, I don't have any other choice. And if I have to choose only one, I'll go for hyperangulated blade, because this gives you a better view. And it is definitely helpful in rescue or difficult airway situation.
Absolutely, absolutely.
thank you, sir.
Dr. Samiksha, there are no more questions in the chat box, right? So it's time to close the session. Thank you so much, Dr. Shah, sir. It was a very, very informative and nice talk in a very comprehensive manner. And thank you for sparing time today for our Rsacp and for our postgraduates. Thank you very much.
Thank you. Thank you.
Thank you, sir. It was a pleasure, sir.
Thank you so much, Dr. Amit Shah, and thank you, our chairperson, Dr. Samiksha Kanuja, and Dr. Amit Kohli, for taking this interactive session and giving your own experiences and inputs. So let's move to the last and one of the important session, because we are so fancy about ultrasonography and it is coming into clinical picture, and all of us are using it in some way or the other. And we have an interesting session now in ultrasounds in airway by the Clinical Pulse. And more interesting and experienced chairpersons we have with us, Dr. Rakhi Goyal and Dr. Geeta Ahlawat. I think both of them are really the stalwarts. I do not know if I start reading their CV, it will be finishing the time. Dr. Rakhi Goyal in itself is a great person, a great academician, a great researcher, and a great human being. So that's, I think, summarizes all about her with ever always smiling face. Dr. Geeta Ahlawat, the professor from Department of Anesthesiology, PGIMS Rohtak. Ma'am also has great contribution to anesthesiology with good number of publications, the researches, and she's one of the very good speaker at various national and international platforms. So welcome, Dr. Rakhi, and Dr. Geeta, over to you, please.
Thank you, Dr. Rakesh, for your kind words. Dr. Geeta, if it's okay with you, I would take the privilege to invite our very esteemed speaker, Dr. Professor Pankaj Kundra. He needs no introduction. Everyone knows him. His contribution to the field of anesthesia has been immense over decades, and he's one of the most respected senior anesthetists that we know of. He's presently the professor anesthesia and dean academics at JIPMER Pondicherry, and he's had lifetime achievement awards, a whole lot of orations, chapters. He's editing journals, books, and his CV is probably longer than his talk. So I, with Dr. Geeta and I, we would welcome you, sir, and it's a proud privilege, and we're really honored to have your listen to your talk on ultrasound on the airway. Please, sir. We can't hear him, Dr. Rakesh. Can you just check, please?
So this is relatively a new entity which has now come into our armamentarium. And believe me, it's quite useful in many of the cases where you can look forward to airway ultrasound to solve many of your issues. Now, how do we go ahead and what are the acoustic windows? See, for abdominal ultrasound, it was very easy. It's a wide area available. For lung ultrasound, you had the entire rib cage, which is only having the intercostal spaces. But the airway ultrasound, you have a very small area. And believe me, there are 8 acoustic windows which you will have to look at, because a lot of structures are delineated in these small acoustic windows, and you have to make very precise economical movements of the hand to visualize these structures. It's really challenging to do that. So now let's see how we can go ahead. We start from the top, and this is the submandibular region through which all of them would be transverse views. So we'll go from top to bottom. So considering the transverse views, the first view is at the submandible region. After that, you slide the probe and you come to an area where you find that there is hyoid bone. Below hyoid bone, you will find there is a prominence, which is thyroid cartilage. After the thyroid cartilage, you come to a small depression, which is the cricothyroid membrane, which connects the thyroid cartilage with the cricoid cartilage. So already we have seen there are 5 views. We still go down, and this is the suprasternal notch view, which you can see. So you're almost covering 6 views when you go from submandibular region to the suprasternal notch. Now let's go to the parasagittal views. which are the parasagittal views available? We would like to see the structures between the hyoid bone and the thyroid cartilage. So this is the thyrohyoid membrane, which gives us an acoustic window to look at the structures beneath the hyoid and above the thyroid cartilage. Then between the thyroid cartilage and the cricoid cartilage, this is a good view to look at the cricothyroid membrane. And then below the cricoid cartilage, you can again have the view of the trachea. So there are about 8 views which we have seen here, which are available for you to look at different structures which are quite compact and adjacent to each others. How do we go ahead? When you look at the hyoid bone, the first thing which you look at is that it gives you a C-shape or an inverted C-shaped structure, where you will find that below that C-shaped structure, there is nothing visible. It's all black. So why do we need to look at this hyoid bone? It is important to look at this hyoid bone because it defines the various scanning regions. Like for lung, we had various scanning regions. Even for the airway, you would like to have different scanning regions, which are defined as suprahyoid and infrahyoid. Why do we need these kind of scanning regions? Because the type of probe which you're going to use is different. For the suprahyoid scanning region, we generally prefer to use a low frequency curvilinear probe. So when you look at the curvilinear probe and you look at the submandibular view, what structures are visible? This is at the base of the tongue or beneath the mandible, the submandibular space. So this part which you see is the part which is nearest to the transducer. So you get genohyoid, and this area which you see, which comprises of hyoglossus and genioglossus muscles, this is the transverse view of the entire tongue. Below the tongue, if you look at, there is a white line partially visible. This is the palate. So these are the structures which you will be able to see: the tongue and the floor of the mouth, and then the muscles of the tongue, which are defined as hyoglossus and genioglossus. So there are intrinsic and the extrinsic muscles of the tongue which are visible. Now, if you look at the extended mandibular view, why I was telling you of the curvilinear probe, because it fits in extremely well into the space, the curvatures, and you can see a lot of structures which will be of interest to you. The main structures which you want to look in a sagittal plane would be that this is the tongue which you are looking at, mylohyoid and genohyoid muscles. This is the hyoid bone. This hyoid bone in this view is recognized because you see a dark shadow below this white structure. So when you see a dark shadow which is there, that is because of a bone present in proximity to the transducer. And therefore, this will be the suprahyoid region. This would be the infrahyoid region. So in the infrahyoid region, what do you see? You see the epiglottis here. So you will normally look at the epiglottis here, the periepiglottic space, and in the suprahyoid regions, you see the tongue, you can see the palate here. So these are the structures which will be visible. Now come to the infrahyoid scanning zones, where you require a linear transducer or a transducer with high frequency. This is an interesting space because you, through the thyroid membrane, you will be able to see the epiglottis. So this white structure is the epiglottis. This is the air mucosal interspace. This is the periepiglottic space. So what do you find here? You can look at the shape of the epiglottis and you can look at the pre-epiglottic space, how much space is available. If you're not sure whether it is an epiglottis or not, you can ask the patient to swallow or slightly move the tongue. But remember, the moment you move the tongue, the patient moves the tongue, the view will disappear, because these are very compact areas and they are very susceptible to movements of the structures. Now, how does the normal epiglottis look like? If you look at the normal epiglottis here, when I'm doing the structure, you find this is the epiglottis which is visible. This is the periepiglottic space. So normally the amount of width the epiglottis will offer you is about less than 0.5 centimeters. Now, if you have an epiglottic edema, into this video, if you look at, this is the hyoid bone, I'm slightly sliding the transducer down and look at this epiglottis. It is so much swollen, this whitish part which you see, this is more than almost 1.5 centimeters. So there is epiglottic edema in this patient. And the problem with epiglottic edema, if you diagnose, is that the patient is likely to aspirate, because the epiglottis is the structure which directs the food towards, or the fluid or food towards the esophagus. And if it is swollen, if that cartilage is swollen, it is not able to move. And in that likelihood, the patient, in that scenario, the patient is likely to aspirate. Now let's come to the thyroid cartilage. So below the hyoid bone, we saw the thyrohyoid membrane through which we saw the epiglottis. Now let's come to the thyroid cartilage. This is of interest to all anesthetists because you're able to see the vocal folds or the vocal cords. So initially, when you enter the larynx, when your probe is able to see through the thyroid cartilage, you will see false vocal cords, and the thyroid cartilage would be a V-shaped, inverted V-shaped structure. This is sternomastoid muscles. So you just have to tilt your probe a little bit downwards, and then you will be able to see the vocal ligaments and the arytenoid cartilages. These are important structures for you to have a look at. So I'm just showing you a video of just below the thyroid cartilage, how the vocal cords will look. Now look at this. This is the inverted V-shaped structure of the thyroid cartilage. And what we see here is the vocal cords are moving bilaterally. They're adducting and abducting symmetrically. And these small hyperechoic structures which you see here at this point and at this point, these are the arytenoids. So I'll just pause the video at a particular point to show you the arytenoids. So these are the two arytenoids. Both these two arytenoids are at the same level, and the vocal cords are attached to the arytenoids, the vocal ligaments. So all you need to look at is whether the cords are adducting completely, right? And whether they are approximating together, and whether they are moving bilaterally symmetrically. If you can diagnose that, you can actually come to a conclusion whether the patient has vocal cord palsy or not. So this is a patient which we looked at after thyroidectomy. So when we looked at this patient after thyroidectomy, we found as soon as I play the video, that only one side of the vocal cord is moving, this side. This one is stationary, right? So only one part of the vocal cord comes and meets this, this vocal cord, but this vocal cord is not moving at all. So we could diagnose easily that this patient has a partial vocal, a partial vocal cord palsy of one side. The other important aspect which we looked at was that this is a video endoscopic picture of the vocal cords which we took after we diagnosed on the bedside in the OT table that the patient has unilateral vocal cord palsy. The arytenoid on left vocal cord was higherly placed than that on the right side. Similarly, a view is seen here in the telescopic view. The reason is the patient's vocal cord here on the left side is completely relaxed. It has lost its tone. And that tone is lost because of the paralysis of external branch of superior laryngeal nerve. So that's the reason you can see that this patient has two nerve palsies. One is a recurrent nerve palsy. The other is a superior laryngeal nerve palsy. The other important aspect of airway ultrasound, how it can be useful to you is, look at this case. This is a case posted for exploratory laparotomy for an ovarian tumor. We took an X-ray neck because she had a thyroid swelling. The trachea is grossly compressed in the AP view. We took an MRI scan and the trachea is moved laterally towards the left side. This thyroid tissue has compressed the trachea so much that the diameter available is only 0.56 centimeters. So we would label this case as a difficult intubation case. Now, what do we believe in? These are all static images. And we are taught in our textbooks that if there is a tracheal compression because of thyroid, you try to lift the thyroid up and see whether the tracheal lumen expands. But here, lifting of the thyroid is not going to be helpful. The reason is trachea is not posterior, it is pushed to the side. So what we thought was, let us push the thyroid towards the other side, the right side, and see if this tracheal lumen expands. This patient had mild stridor as well. So now I'm just going to show you the pictures. This is a dynamic assessment. So you can't do a dynamic assessment with X-rays or with MRI scans if you have them. But here with ultrasound, what we tried to do was, this is the thyroid gland which we have here. So we tried to push the thyroid gland towards the opposite side. Now, when we push the thyroid gland towards the opposite side, we could see that the tracheal lumen actually expands. So let me show you the video. How we did was, this is the trachea, this is the thyroid. Now I'm pushing the thyroid here. Look how the trachea has expanded. If I release my push, then the trachea comes back to be smaller in diameter. It is again, the compression is not released. So you have to push the trachea to release the compression and have a better diameter or expand the lumen of the trachea. So when we could demonstrate this, we knew how to handle the airway. And as soon as we did that, the patient objectively said that she is able to breathe better. So that's all what we need to do in case we need to intubate. We can choose a larger size tube. And if the patient is having some sort of a stridor, we just need to push the thyroid towards the other side to expand the lumen. So these are certain advantages of knowing how to do the ultrasound. The next structure which we talk about is the cricoid cartilage, which is below the thyroid cartilage. So what does it tell you? It can actually tell you what can be the endotracheal size which you want to use. But remember, the size of the tube you would have to select would be according to its external diameter. Because when we measure the cricothyroid membrane distance here across this, that should give you a diameter of the tube, external diameter of the tube, which you can accommodate. So there are studies which have been done, and it has been shown that assessing the cricothyroid, the cricoid cartilage distance between across the 2 points here actually correlates with all the formulas which have been devised for selecting an endotracheal tube for pediatric cases. So this is the cricothyroid membrane, just showing you on a video. It is very hyperechoic. This is that shadow which you see here, and this is you will find that it extends on both the sides as I go down. As I go down a little bit, even with a small movement, you will find that the cricothyroid membrane, the cricoid cartilage is visible almost throughout in the 3/4 area, except for the posterior part, because that is where you cannot get across the beam because of the cricoid cartilage, which is again a structure which is bony. Now, important part which I want to emphasize is the cricothyroid membrane. Cricothyroid membrane is best seen in a parasagittal, or I would say a sagittal section. So you need to identify the cricothyroid membrane which lies between the thyroid cartilage and the cricoid cartilage. You have to place the probe directly here vertically between the two cartilages, and you will be able to find the cricothyroid membrane, which can be identified to do cricothyroidotomy or percutaneous dilatational tracheostomies. So how do you identify the cricothyroid membrane? Look at this video. This is the trachea. You see a string of pearls. This is a cricoid cartilage, this semicircular hypoechoic structure. And this is a V-shaped structure with a hump. This is the thyroid cartilage. So if I have to identify, I come from the tracheal side, identify those tracheal cartilages, identify this hump. This is always going to be of thyroid cartilage, and then try to see for this black semicircular hypoechoic structure, the structure between these two would be the cricothyroid membrane, and this is the cricothyroid membrane. If you look at the structures above the cricothyroid membrane, this is the epiglottis, which is moving. So you come inferiorly. So I'll just play the video again. So what you do is come inferiorly from the trachea, identify those tracheal cartilages. This semicircular hypoechoic structure, which is cricoid cartilage, the hump, the thyroid cartilage, and the structure between the two cartilages would be the cricothyroid membrane. This is the tracheal rings. The video is replaying. So you start from trachea, come upwards, try to recognize these two structures simultaneously in a single frame, and the structure which is the line which is hyperechoic between these two cartilages would be the cricothyroid membrane. So you can use the cricothyroid membrane easily to find out if the exact area where you want to do a cricothyroidotomy, or also you want to do the PDT. So here is the way you can do it. You put a cannula here and just try to put that part here beneath the transducer. And once I'm able to fix the cannula here, I remove the transducer, and with a marker pen, I will mark the cricothyroid membrane. Now let's come to the sternal notch, suprasternal notch. What does it tell us? There are different things which you can look at. You will find that this is the thyroid gland which you're looking at, the isthmus of the thyroid gland, the tracheal cartilages, and these are comet-shaped artifacts from there. So what do you want to look at? You can actually confirm whether the endotracheal intubation has happened or not. Normally, the esophagus by the side of the trachea would be a collapsed structure, just like the antrum, which I showed you in the abdominal ultrasound. But if the tube goes inside the esophagus, it will become like a double hump. That is, it will become just like a second trachea. So if you have a double trachea appearance, then for sure your tube has gone into the esophagus. So to look at this picture here, this is the trachea and this is the esophagus. Now it is not collapsed. It has got some hypoechoic shadow with small dot here. What do you think this is? This is a nasogastric tube which is going into the esophagus. This is the internal carotid artery, and this is probably small amount of residue in the nasogastric tube which you are able to see. So it's important to identify the esophagus here. Now, if I play the video here, it's quite easily seen. This is the trachea, which I was talking about. This is thyroid gland, this is internal carotid artery, and this area, this is the esophagus, which is being occupied by a nasogastric tube, and it has got fluid and some particles from the gastric residue coming up. So this thyroid the esophagus here is actually filled up with some of the fluid, and that is why it is being shown here like that. Now, the other part, which I told you that you should be able to confirm the tracheal intubation through it. So just let me play the video. This is a tube going inside the esophagus. If you look at it carefully, I'm just putting the trachea, the ultrasound while the person was intubating, and I find that the tube has gone into the esophagus, which was a collapsed structure. It has become a double trachea. Now, can you do ultrasound guided intubations? Yes, this is something which we have published. Normally, you see double tracheas, both of them are air shadows, you're not able to identify. But if you put a stellate inside the tube, this stellate is a hyperechoic structure which you can guide towards the vocal cords, and that would help you to identify where your tube is, and you can actually go and intubate the trachea like we have done here without using laryngoscope or with assisted or limited laryngoscope. People have done this earlier, but they have not used the stellated tubes, which we would like to use. Thank you very much. That's all I had to give you. I'm thankful to the organizers to have given me this opportunity to share my views about ultrasound of the airway.
Dr. Geeta, would you like to say something?
Very good evening, everyone. Sorry to join a little late. It was a wonderful lecture, and everything seems so easy, as explained by Dr. Pankaj sir. And I hope it is beneficial to everyone who's watching it. It was a wonderful lecture, very beautifully presented, and especially the videos, their quality and all. And of course, the beautiful explanation that Sir always does. Thank you so much, everyone.
Thank you, sir.
Thank you. Thank you, ma'am.
Real,
Thank you.
real pleasure. I have actually no words. Ultrasound is very close to my heart, and airway, all your images and videos were superb. I wish when I put the probe, I get it as labeled as you showed. The only thing when we do ultrasound, till we cross the learning curve, is I always wish they were labeled. How do you place, this is a personal question, how you've done ultrasound for various other reasons, I'm sure, various parts of the body. How do you personally feel the ultrasound of the airway, the learning curve in the airway ultrasound vis-a-vis other ultrasounds like for nerve blocks, for line placements? Do you think it's more difficult? Is it more decisive?
Yes, ma'am. It is a little difficult because the reason is that the windows are very small. Just a millimeter of movement of the probe can shift your windows to walk from one structure to another. And there are too many structures which are compact in a particular place. So that's the reason the movement of your transducer has to be very precise to actually visualize what you want to visualize. That's been my personal experience. It's not like a nerve where you can actually insonate across the length of the nerve or the width of the nerve, go up and down. Here, even a millimeter of it, and you find that your vocal cords are gone and you are not able to see them, and you are already at the cricoid cartilage. So that kind of restrictions are there, that your movements of the ultrasound probe has to be very precise. And even the tilting of the probe, you will have to do at various structures. The main mistake which people do is try to extend the neck when they want to do the ultrasound. Remember, it's not something like a laryngoscopic view which you want to look at. The more you extend, the more transducer gets displaced from the tissues, from the skin, sorry. If you flex your neck, then there is a good skin contact of the ultrasound probe with the neck, and then the surrounding or the adjacent tissues are also visualized. So this is these are certain pearls which you learn when you start doing the ultrasound of the ear.
Thank you, sir.
Thank you so much, sir.
That is why we wanted to hear from you. And yes, as you say, it's not easy. So another personal question, that don't you think we should do it on a routine basis, so that when we actually need to take a decision, like if you're putting a PCT, or you have to decide the size of the tube, or you have to decide whether the tube is in trachea or the esophagus, where you have to take a decision on a difficult airway. So if I do it routinely, I would probably be in a better situation to take that decision in a difficult time. So would you suggest that we should now, with the availability of the probe literally with almost all of us, should we not start doing it routinely?
I totally agree with you, ma'am. It has to be done routinely. The problem with us is that we learn in a retrospective manner. See, the fiber optic scopes will be kept inside the cupboard till a difficult case comes and you try your hands on a difficult case. Rather than trying it on certain normal cases, at least doing a orotracheal fiber optic intubation in majority of the cases to get a hang of how fiber optic has to be used in normal airway before you start using it in difficult airway. That's how we should step up our learning curve. But if you start doing ultrasound when you are in a problem, I'm sure you will be lost. And it has to be done routinely. You at least look at the airway once in a while, in at least one case a day, to see what is happening, what structures you're going to see. And that definitely helps in assuring you a faster learning curve. I totally agree with that.
I'm so happy you said that, sir, to all our listeners here, that putting a probe just once in a day won't hurt anything. It doesn't cost you anything. It's non-invasive. If it's available to you, do it, so that one day, even after doing 100 normal scans, one day, if you're able to take help of it, it's worth it. So one more thing. Sorry, I'm asking you too many questions. How would you find doing an airway ultrasound in a child, say 5 years and below? Can it be really, there's very limited literature. So do you have any experience? You want to give any tips?
No, please.
We can't hear you, sir.
Ma'am, the issue is you need to familiarize the kid with the ultrasound support. They need to comfort the child. Am I audible?
Yes.
I'm sorry, I'm in a hospital here and I don't have a good internet connection.
No worries. No worries.
So the problem with the pediatric airway ultrasound is that you need to familiarize the child with the ultrasound and the dark environment, which they would never accept. So the parents have to be with the child. You slowly can dim the lights, or you may have to perform the ultrasound in an illuminated place without having a dark place there. And the parents play a crucial role. At times, the parents can hold the probe and you hold the hand of the parent on top of this to see what structures you're going to look at. The second aspect is the anatomy of the airway doesn't differ much in a 5 to 8 year old child as against the adult. It's almost the same. And there's not much of differences which you will see. Below to 3 years, like 2 years and all, that is the place where you may find certain differences between the anatomy of the airway. And then again, that place is too small with too many things around to actually know what you're going to see. So when you look at a pediatric airway ultrasound, your objective has to be very clear that what are you going to look at? So identify your objective, that this is what I need to focus at, not at everything. If I look at this and this is my target, then most of the time you will be successful.
I would say, sir, one is for assessment of the airway. So after you have given a bit of sedation, so one assessment, does this airway is really difficult. Second, the tube size. There are a few studies where they give an estimate of tube size, so that you select the best tube instead of changing tubes. It could be too tight, too loose. Of course, with the cuff tube, the problem is less. So maybe if we work more on the topic, we'll get some more information in the future for some children get the right
to my experience, the formula related tube sizes which we determine versus the ultrasound, the correlation is quite good. So it doesn't matter whether you use the formula based external diameter selection or ultrasound, there is not much of a difference, to be very frank with you. So my assumption of the way I do at things, I may be wrong as a person who has practiced anesthesia for last 30 years. If it is a 4.5 size tube, rather than choosing a 4.5, I may err on using a 5 size tube. 5 size tube.
Okay.
If I'm going to pass the tube and if it is not moving aside, I immediately change to 4.5. So that if you put a 4 size initially, and you're going to put in a plain size tube, and if there is a leak, you will have to do a repeat laryngoscopy, take out the tube, put in a 4.5. So rather than
okay. We've lost you again, sir.
All those things are out of question. But yes, this practice may now become obsolete because you have cuffed endotracheal tube. So then it is better to use a size smaller, because anyway you will be able to cover up the leak with the cuff tube. So that's what my suggestion would be, rather than erring on a smaller size where you can have leak, then you struggle, then you would repeat the laryngoscopy, repeat intubation, at least do it at one go, and things would be all right. But ultrasound doesn't make much of a difference as far as tube selection is concerned. And ultrasound would not be able to give you much help as far as anticipated difficult airway is concerned. The only thing where ultrasound can help you in pediatrics is probably identifying the cricothyroid membrane. That's it.
Thank you, sir. Some chat box questions have come up now. Dr. Geeta, would you like to ask them?
Just a second, ma'am.
So somebody, I'll just take one. LMA placement. Somebody's asked about the LMA placement with the ultrasound, the correct LMA placement.
Okay.
If you ask me about correct LMA placement, I have no experience, so I would not be able to make a comment on it. Sorry, I have limited experience with LMAs. I've never tried ultrasound with LMAs.
Second is about the DLT, sir. How to determine size of the DLT with ultrasound?
See, ma'am, the ultrasound DLT size would almost relate to the external diameter of the trachea, which you are going to look at. And the thing is, if you can measure it with the ultrasound at that particular time and then see what transverse diameter you are getting and correlate it to the French gauge which you have with the DLT, it may work out well.
Yeah, it may be of use on that. Yes.
Yeah.
Okay.
There is a question by Dr. Amit Shah. Role of ultrasound, airway ultrasound for a superior laryngeal nerve block.
Yes, you can use it. There are published reports where people have used ultrasound to locate the membrane, and you can do that part of you can do that. No, there is no problem with that. You can always try it out.
I think the more we use, the more avenues we will discover and will become better with regular use, like we did with using ultrasound at different places. The indications will come up. I'm quite tempted to use for laryngomalacia in neonates. We often get kids with stridor, and we do a fiber optic bronchoscopy to see whether do we need to do a tracheostomy or not. So we see. So I'm quite tempted to see on ultrasound with the slide that you showed where the arytenoids were at different levels. That was very exciting. So something where the larynx comes together or not, we can see.
Because it gives you a dynamic view on the airway. So that's the beauty about ultrasound.
Yes. So I think I think that's about it. Can we use the parasagittal views for real-time dynamic confirmation of intubation?
Parasagittal views, I would rather go to the transverse views like I showed you when you look at the esophagus. That's much easier to look at, and it takes less time to locate because it is more definitive. So I would still recommend that we use transverse views at the suprasternal notch and just place your probe there while the intubation is being done, and look at the esophagus and see where the tube is going. That's it.
There's one more question, sir. How can you please tell how to assess TMJ mobility?
TMJ mobility with ultrasound is a little difficult to assess, ma'am, to be very frank. I have not tried it, but I think it will be very challenging to see what you're trying to focus at, because it's a bone.
It's
and
a bony shadow, yes.
Bony shadow, what are you going to look at with the TM joint mobility? I don't think it is possible.
Okay, sir. I think that's about all as far as the questions are concerned. Isn't it, Dr. Rakhi, ma'am?
Yes, absolutely, sir. What a pleasure it was to see your slides and understand more and more. And you've certainly inspired a lot of people today to put the probe on the airway and to understand it better. Thank you so much, sir, for your time, for your brilliant talk. Thank you.
Thank you, Dr.
Thank you so much,
Dr.
sir.
Rakhi.
Thank you, sir.
It's my pleasure. It's my honor. Thanks a lot.
You've made it seem so easy, sir. I hope we have the same experience when we do it. Thank you so much.
Thank you, ma'am. Thank you.
Thank you so much, sir. Thank you so much for your excellent lecture as always. And a lot of appreciation for all the three wonderful speakers, because they are the real giants in their respective field, and whatever they have shown us is their experience for last so many years. I think thank you so much, and thank you, Chairperson, for this session, Dr. Rakhi and Dr. Geeta, for taking it such an interactive session. I think many questions are still coming up, so I think Dr. Kundra will be available with us on some other platform, some other place, again with this the gamut of knowledge and experience. Thank you so much. So I think any questions from anybody, they can unmute themselves and they can ask questions from any of the three speakers. We have Professor Kundra with us, Dr. Patwal, Dr. Shah with us. Any comments, any opinion from your side? We have another 2-3 minutes, so we can take it forward. So if none, so I will just like to have a vote of thanks. My sincere thanks to all the speakers today, Dr. Apesh Patwal, Dr. Amit Shah, and Professor Kundra for wonderful session. My senior thanks to all the chairpersons who has done a wonderful interaction and sparing time for chairing today's session, Dr. Josna, Dr. Pratibha, Dr. Amit, Dr. Samiksha, Dr. Geeta Ahlavat. Special thanks to Dr. Rakhi Goyal, who is always like a mentor to me and always guides me how to take the webinar forward. So thank you, Dr. Rakhi Goyal, for all the support and helping us, the Rsacp, in coordinating this webinar. And I also sincerely thanks to all the dignitaries of Rsacp, Dr. Indrani Hemant Kumar. She could not join today for some busy schedule. Sincere thanks to Dr. Naveen Malhotra. Sincere thanks to Dr. Vishal Singla, Secretary, Rsacp, and all the eminent members, Dr. Vijaya Lakshmi, Dr. Mayank, and everybody from Rsacp who has given this opportunity for organizing today's webinar of the theme Airway Clinical Terms from Experts. And finally, thanks all the participants who have spared time and they have put their queries, their questions that has encouraged us to take the things further. And let's meet on the next Rsacp webinar soon with a more interesting session. And thank you so much once again. Thank you, everybody.
Thank you,
Dr. Rakesh. Thank you. Thank you, everyone. Good night.
Thank you. Thank you very much.
Good night.
Good night.
Thank you, everyone. Good night.
Thank you. Thank you.
Thank you, Rakesh. Bye.
Thank you, sir. Thank you so much.
Rakesh, you are the host, so you have to end the meeting.
Okay, right, sir. Okay, I will.
Thank you, sir.
Congratulations.
Thank you, ma'am.
Nicely done.
Thank you so much.